Benign sleep transients are normal, age-dependent EEG grapho elements that appear during drowsiness and sleep. Their sharp contours, rhythmicity, or high amplitude can resemble epileptiform abnormalities, particularly in newborns and young children. In this presentation, we will use a systematic pattern recognition approach to distinguish normal developmental transients from pathological discharges and avoid unnecessary diagnoses and treatment. Next slide, please. The interpretation of any transient waveform should begin with 5 questions. Is it appropriate for the patient's developmental age? In which behavioral or sleep state does it occur? What is its polarity? Does it have a broad physiological field or a restricted pathological field? Finally, does it remain stable or does it evolve in frequency, amplitude, morphology, or distribution? Normal sharp activity is commonly overcalled because sleep increases waveform amplitude and sharpness. The morphology alone is therefore not enough. Age, state, field, background, and evolution must always be considered together. Next slide, please. The developmental timeline provides the first essential clue. In premature and term newborns, the major benign transients include delta brushes, temporal theta bursts, sporadic neonatal sharp transients, and frontal sharp transients. During infancy, neonatal patterns gradually disappear as vertex waves and sleep spindles emerge. Hypnagogic hypersynchrony becomes recognizable during early childhood. With further maturation, K-complexes, well-formed spindles, and positive occipital sharp transients of sleep become established. Benign epileptiform transients of sleep, or BETs, are predominantly an adult pattern and are uncommon in children younger than 10 years. Persistence of any transient beyond its expected developmental window should prompt careful reassessment. Next slide, please. A delta brush is composed of a slow delta wave, usually between approximately 0.3 and 1 Hz, with superimposed fast activity in the 8 to 20 Hz range. The fast component appears to ride on the slow wave rather than forming a separate spike followed by a slow wave. Delta brushes are most prominent in premature infants, particularly around 28 to 32 weeks of postmenstrual age. Their distribution may be central, occipital, or temporal and changes with maturation. In contrast, epileptiform fast-slow complexes usually contain a distinct spike or polyspike followed by a slow wave. They may be focal or generalized and are not restricted to the normal developmental window. Features raising concern include marked persistent asymmetry, repetitive trains, clear electrographic evolution, and persistence beyond approximately 44 weeks of postmenstrual age. Next slide, please. Frontal sharp transients, also called N-Coaches frontals, are broad biphasic waves occurring predominantly during quiet sleep near term. They usually begin with a surface negative sharp component followed by a broader positive component and are maximal over the frontal or frontopolar regions. Moderate asymmetry between the two sides can be physiological in neonates. The important clues are the broad frontal field, appropriate age, quiet sleep association, and absence of evolution. Pathological frontal spikes are more likely to persist beyond the expected neonatal period, show a restricted and reproducible field, have a prominent aftergoing slow wave, or occur with focal slowing, seizures, or an abnormal background. Next slide, please. Sporadic neonatal sharp transients are isolated, non-rhythmic sharp waves that may occur independently over several regions. They are particularly common during quiet sleep and can be multifocal in an otherwise healthy newborn. The major diagnostic error is to label every neonatal sharp wave as a seizure. A neonatal seizure requires sustained rhythmic activity with clear evolution in frequency, amplitude, morphology, or spatial distribution. Before diagnosing ictal activity, examine the continuity and symmetry of the background, determine whether the sharp transients are periodic or repetitive, and look for a consistent electroclinical correlation. Isolated multifocal waves without evolution are generally not seizures. Next slide, please. Temporal theta bursts are short runs of rhythmic, often sawtooth-shaped theta activity seen primarily in premature and neonatal EEGs. Their sharply contoured appearance can resemble the beginning of a temporal seizure. The distinction depends mainly on age and evolution. A benign temporal theta burst is brief, usually less than 10 seconds, remains stable in frequency and amplitude, and may alternate or shift between temporal regions. An ictal temporal rhythm typically becomes more organized, changes frequency or amplitude, spreads anatomically, or develops associated clinical manifestation. A theta burst occurring outside the appropriate premature or neonatal age window deserves greater scrutiny. Next slide, please. Vertex sharp waves and K-complexes are normal NREM sleep graphoelements, but can appear remarkably sharp and high in amplitude in children. Vertex waves are usually negative, maximal at the central midline, particularly C, and have a broad symmetric field. They may occur singly or in runs during light sleep, but they do not evolve. K-complexes are large biphasic slow transients, also maximal frontocentrally, that occur in stage N2 sleep. They may be spontaneous or stimulus-induced and are often followed by a sleep spindle. Epileptiform central discharges usually show a more restricted field, consistent pathological morphology, a prominent after-going slow wave, or associated focal slowing. Generalized spike and wave activity is repetitive, bisynchronous, often frontally dominant, and may show evolution or clinical correlation. Next slide, please. Sleep spindles are waxing and waning bursts of rhythmic activity that emerge during early infancy and progressively mature through childhood. They are initially most prominent over the central regions and may be asynchronous between hemispheres during the first months of life. Early spindle asynchrony can be normal, and complete synchrony is not expected immediately. With development, spindles become more organized and increasingly synchronous. The clinically important finding is not a single asymmetric spindle, but persistent asymmetry across adequate NREM sleep. Marked amplitude reduction, consistent unilateral absence or failure of spindles to develop within the expected corrected age range may suggest ipsilateral structural or functional dysfunction. Next slide, please. Positive occipital sharp transients of sleep or posts are identified by their positive polarity, occipital maximum, and characteristic checkmark or sail-like configuration. They often occur in trains during NREM sleep and may be synchronous or independently expressed over the two occipital regions. Because scalp negativity is conventionally displayed upward, the positive phase of a post usually points downward on the EEG display. Occipital epileptiform spikes are more commonly surface negative, irregularly repetitive, and may persist during wakefulness. Associated focal slowing, visual symptoms, or a convincing seizure history further supports a pathological interpretation. Next slide, please. Hypnagogic hypersynchrony is a normal sleep onset pattern characterized by generalized high-amplitude rhythmic activity, usually between 3 and 5 Hz. It has a smooth waxing and waning envelope and occurs as the child enters sleep. The waveform may be sharply contoured, but it lacks a consistent spike component and does not evolve electrographically. The waking background is normal, and the activity disappears as sleep deepens. The principal error is to mistake it for generalized spike and wave activity or an electrographic seizure. The sleep onset timing, absence of definite spikes, self-limited course, and lack of evolution are the most useful distinguishing features. Next slide, please. Benign epileptiform transients of sleep are also known as benign sporadic sleep spikes or small sharp spikes. They occur in drowsiness and light NREM sleep, particularly stages N1 and N2, and are not present during full wakefulness. They are usually monophasic or diphasic temporal sharp transients. A typical event is approximately 60 microvolts in amplitude and 60 milliseconds in duration, although most remain below 90 microvolts and 90 milliseconds. Their field is broad and centered over the mid-temporal region rather than being confined to one electrode. They may alternate between sides or appear in homotopic contralateral regions. They remain isolated and non-evolving and do not form repetitive trains. Because BETs are uncommon in children younger than 10 years, similar temporal transients in a young child should be interpreted cautiously. BETs most closely resemble focal interictal epileptiform discharges. Repeated examples within the same recording help make the distinction. BETs generally preserve a highly similar monophasic or diphasic morphology from one occurrence to the next. Their aftergoing slow wave is usually small or absent. The field is broad and temporal, and lateralization may shift between hemispheres. Focal interictal discharges tend to have a more confined and stable field. Their amplitude and morphology may vary, and they often have a prominent after-going slow wave. Independent focal slowing in the same region also favours an abnormal focal process. A single isolated temporal sharp transient may remain indeterminate. In that situation, it is safer to describe the finding precisely rather than overdiagnose epilepsy. Next slide, please. 3 temporal sharp patterns require direct comparison. An electrocardiographic artifact is time-locked to the R wave. It is often most prominent at ear or temporal electrodes and may occur bilaterally and synchronously. Direct comparison with the ECG channel is the most reliable method of identification. Wicket spikes have an arciform appearance and resemble fragments of an underlying wicket rhythm. They may occur during wakefulness, are often larger and more variable than bets, and may appear in trains. They do not have a prominent after-going slow wave. Bets occur only during drowsiness or light NREM sleep. They are small, monophasic or diphasic, have a broad temporal field, are not heartbeat locked, and do not form repetitive trains. Next slide, please. Consider the EEG of a 4-year-old child showing generalized high-amplitude rhythmic activity at 3 to 5 Hz during sleep onset. The activity waxes and wanes, has no definite spike component, and does not evolve. The possible interpretations include an absence seizure, hypnagogic hypersynchrony, generalized spike and wave activity, or electrographic status epilepticus. The most appropriate interpretation is hypnagogic hypersynchrony. The decisive clues are the sleep onset state, smooth waxing and waning, absence of a definite spike, lack of electrographic evolution, and preservation of a normal waking background. Next slide, please. The safest approach to pediatric sleep transients is systematic rather than impressionistic. Describe the morphology, polarity, anatomical field, sleep state, evolution, background, and any clinical correlate. Always compare the waveform with the child's developmental age and determine whether it occurs within the expected maturational window. Identify red flags such as persistent focality, marked asymmetry, repetitive or periodic occurrence, abnormal background activity, and electrographic evolution. When uncertainty remains, careful description, clinical correlation, follow-up, or repeat recording is preferable to premature labeling. Recognizing developmental context is the key to preventing normal sharp sleep activity from being mistaken for epilepsy. Next slide, please. Thank you for watching. I hope this presentation has provided a practical framework for recognizing benign sleep transients and distinguishing them from epileptiform abnormalities in newborns and children.